good morning. It's my pleasure and honor to have you all here at Urology and Referral Center, Mansoura University, to start the scientific activities of the 12th International Hemodialysis course and the 5th course dedicated for African countries in collaboration with Egyptian Agency of Partnership for Development. I'm going to start the scientific session with dimensions of renal replacement therapy and hemodialysis, and I'm going to highlight some comparative aspects between the different renal replacement therapy modalities. Again, you are welcome here at Mansoura Urology and Referral Center, our very important guests from 14 African countries. Regarding the dimensions, it is very difficult to speak about details, and I'm going just to present ideas. So this presentation will include these sectors. I'll start with the epidemiology of the problem of renal replacement therapy and end-stage kidney disease, the outcome of replacement therapy regarding patient mortality, hospitalization, cost, and comorbidities, impact of uremia and end-stage kidney disease on different body systems, because renal failure affects all body systems. No single system is exempted from these bad effects. The issue of vascular access, because we cannot do dialysis without vascular access. And then what about the indications and when to start dialysis? I think it's a very hot issue and different strategies for this point. And then some hot issues and innovations in the field of hemodialysis. Let us start with the epidemiology. We are not trusting the statistics about the prevalence of chronic kidney disease, but we trust the statistics presented within this map because it reflects the prevalence of treated end-stage kidney disease either by dialysis or transplantation per 1 million population. If you look here at the Egypt, here this is the prevalence between 500 to 1,000 per million, and one of important point is the data from African countries are either not reported or the data is not available. Regarding the prevalence, the current United States renal data system shows some comparative epidemiology data about end-stage prevalence in different countries. If you look here, the prevalence may be so high, like Taiwan, it is more than 3,300 per million population to have end-stage kidney disease, followed by Japan, 2.5 thousands, and you can find a big variation from country to country. So the prevalence of end-stage is variable from the highest prevalent countries to the lowest prevalent countries. This is the figure that shows the top 10 countries according to the prevalence of end-stage kidney disease: Taiwan, United States, Korea, and you can follow the names of countries. One of important issue, as there variations in the epidemiology of end-stage kidney disease, there is variation as well in the modality of replacement therapy. What are the different modalities for renal replacement therapy? There are principally two modalities: renal transplantation and dialysis. And dialysis is either hemodialysis, and this is the majority, and peritoneal dialysis. If you look here, this color reflects renal transplantation, and this color reflects hemodialysis. For the majority of countries, the major renal replacement therapy is hemodialysis. And this is regarding the United States. Again, this is the prevalence, the trend of end-stage kidney disease prevalent cases as shown by the modality of management of renal replacement therapy. As you see, the trend of prevalence of hemodialysis is increasing every year. This is from the 1980 up to the current state. Hemodialysis is expanding. Transplantation is increasing as well, but still a lot of patients are waiting transplantation or unfit for transplantation, and peritoneal dialysis constitutes the minority of replacement therapy. Regarding home dialysis, this is the data from Mississippi, is still a minority. Low number of patients are supported by home dialysis, and the most common home dialysis is peritoneal dialysis, as reflected by blue bar colored here. Blue colored bar reflects peritoneal dialysis, and the green colored bars refer to the in-center hemodialysis. So the majority of patients are supported through in-center hemodialysis, and few percentage of patients are supported by peritoneal dialysis, and still home hemodialysis is very few. Again, from United States, this is the United States Renal Data System, shows peritoneal dialysis is the commonest home dialysis, but still the trend is low for home hemodialysis. What are the causes of end-stage kidney disease? Still, the diabetes is the leading cause, followed by hypertension, glomerulonephritis, and cystic kidney disease, principally polycystic. And a major fraction of patients is still the original kidney disease is not known. Regarding the cause in different countries, you'll find variability as well. For example, in Egypt, the most common cause is hypertension, and we should be careful when we read hypertension as the cause of end-stage kidney disease, because chronic kidney disease may lead to hypertension. So there are prerequisites to consider hypertension as an original kidney disease, either to have biopsy proven benign nephrosclerosis or the long duration of hypertension that precedes any renal manifestations. Regarding the age, you'll find here end-stage kidney disease affects all age spectrum. No age is exempted from early life up to the very old age. All of these age ranges can suffer from renal failure and supported by renal replacement therapy modalities. Regarding gender, if you look here, all through different countries, this color is reflecting the male gender. Male gender has higher incidence and the prevalence. This is the prevalence of end-stage kidney disease development, and the progression of chronic kidney disease is more fast in men in comparison to women. Except here in Taiwan, if you look here, the progression in female is faster than males. Why? CKD progression is more common in male. Exactly, we don't know. Is it related to estrogen or testosterone? We don't know. Here, this is one of the most recent publications regarding sex-related disparities in CKD progression. Here, this is the number of patients in this cohort study. This is the women and this is men, the data confirms that rate of progression of chronic kidney disease is more common in men than women. Regarding outcome, survival, as you see, in comparison to hemodialysis, transplantation offers better survival. And irrespective to the age of the patient, renal transplantation is associated with better survival. This is the lighter colored bar, shows the survival is superior in comparison to the darker one, which reflects hemodialysis therapy. So this dots refers to general population. So renal transplantation is associated with better survival than dialysis, and this is from European renal data. Regarding the United States, again, this is death rate per 1,000 patient years. Here, this is the transplantation, and this is the dialysis. You can see the great difference between death. So the survival advantage is evident for transplanted patients. The difference between hemodialysis and peritoneal dialysis, in the past, mortality was more common in peritoneal dialysis in comparison to hemodialysis. Currently, there is no significant difference, or even mortality for hemodialysis patients exceeds mortality in peritoneal dialysis. Hospitalization, so the outcome I presented, mortality, and then hospitalization. Admissions for dialysis patients is more common than transplant patients. Not the admission rate, but also the hospital days per patients per year is higher in hemodialysis in comparison to transplantation. So mortality is more common in dialysis. Again, hospitalization is more common, and this is the last point, the expense and the cost. Here, the transplantation saves money, and the expenses of dialysis, hemodialysis, is significantly more expensive than renal transplantation. And this is the expenditure in thousands per person per year. This is for transplantation, peritoneal dialysis, hemodialysis. So in the United States, hemodialysis is the most expensive renal replacement therapy modalities. And this is from Sweden. Do kidney transplantation save money? This was the question of this study, and the data confirms that transplantation saves money. This is why the center is founded, and the founder is our great professor Muhammad Ghanim, who founded the center and transplantation in Egypt and I think in the Middle East. Currently, we have 3,010 cases. The majority of them are live-related kidney transplant recipients. And one of important criteria that we have in the center, we have the transplantation done in the center. All recipients are followed up, and donors follow-up is also established since a decade. Regarding impact on different body systems, as I mentioned, renal failure, end-stage kidney disease, and renal replacement therapy have their effects and impact on all body systems. I'm going to start with cardiovascular. Why? Because it is the most common cause of death in chronic kidney disease, dialysis, and transplantation. If we look at the United States renal data system, this color reflects hemodialysis, peritoneal dialysis, and transplantation. What do you see? The prevalence of any cardiovascular disease is very common in hemodialysis, to the extent 70% have cardiovascular disease. So it is very high prevalence of cardiovascular disease in hemodialysis, peritoneal dialysis, and transplantation. Cardiovascular disease may be coronary artery disease, acute myocardial infarction, heart failure, valvular heart disease, cerebrovascular accidents and transient ischemic attack, peripheral arterial disease, atrial fibrillation, sudden cardiac arrest or ventricular arrhythmias, thrombosis, either DVT or pulmonary embolism. So these, as you see, the cardiovascular disease is very common in renal replacement therapy modality, especially hemodialysis. If we look at age, please focus on this color that reflects the young age between 22 to 44 years. Here, more than 50% of these young age groups have cardiovascular disease. So it is quite terrible. Even in pediatric, this is a very recent review about cardiovascular morbidity and mortality in pediatric patients in dialysis milieu. We may find all these factors that can lead to cardiovascular morbidity and mortality. Dialysis itself, infections, uremic toxins, disturbance of gut microbiome, intestinal dysbiosis, which is common in dialysis patients, the effect and the impact of primary disease, genetic predisposition, CKD MBD profile, high FGF23, vitamin D deficiency, metabolic acidosis, oxidative stress, anemia, vascular calcification, malnutrition. All these factors increase the development of cardiovascular disease and morbidities. Regarding heart failure, what the type of heart failure that we may find in hemodialysis patients? We may find all types of heart failure, systolic, diastolic, or both systolic and diastolic, or unspecified nature. I think one of important reasons why heart failure is prevalent in hemodialysis patients, one factor is the presence and dependence on arteriovenous fistula, especially if the fistula is of high volume, high flow. So we should look at fistula. We consider creation of lower forearm fistula, especially in candidates at higher risk of cardiovascular disease, because proximal fistula increases the burden on the heart in comparison to distal one. Monitor blood flow in arteriovenous fistula by surveillance, and consider reducing the flow in the very high flow fistula. And I think this is a new trend in vascular surgery. Consider routine ligation of arteriovenous fistula in stable kidney transplant recipients, particularly high flow upper arm fistulas. A backup arteriovenous fistula in PD patients should be limited, and I don't recommend it at all to have both PD and vascular access for hemodialysis. Ligate or reduce the flow in an arteriovenous fistula in patients with heart failure and or pulmonary hypertension, particularly following renal transplantation. So this is the summary of recommendations to reduce the burden on the heart. Regarding the impact of the presence of cardiovascular disease on just 2 year survival. Here, if the cardiovascular disease is not present, this is a survival, and if it is present, survival is drastically reduced and the mortality increases. So survival drops from 82 to 66 in the presence of coronary artery disease. And you can look at the different category of cardiovascular disease and its impact on 2-year survival. And this is the impact of cardiovascular procedure on the survival. PCI, primary coronary intervention, CABG, coronary artery bypass grafting, and other procedures. And today we will have a presentation for Professor Mahmoud Youssef about the coronary intervention in hemodialysis patients. Blood pressure, it's very important. Just 2 points. Is there an ideal target for systolic blood pressure in hemodialysis? Look here at the data. Here it seems that survival is perfect for patients with systolic blood pressure between 140 to 160. And then the hazard ratio of mortality increases if we go down or we go up. So the key message from this data is whenever we have patients on hemodialysis with pre-dialysis hypertension, we should give time to volume control. And we shouldn't be rushing in giving antihypertensive, because rapid rushing prescription of antihypertension may lead to intradialytic hypotension and prevent us from optimizing the volume status. What about the choice of antihypertensive in dialysis patients? In chronic kidney disease patients, the ACE inhibitors or angiotensin receptor blockers are preferred strategies for treating hypertension. In dialysis, there is increased sympathetic overactivity. This is why you will find beta adrenergic receptor blockers, beta blockers, is the first drug to be used. But be careful about dialysability of beta blocker. If you use atenolol, use it after dialysis session, because it is extensively dialysable that may precipitate arrhythmias and intradialytic hypertension. So the first order is beta blocker, followed by dihydropyridine calcium channel blockers, and ACE inhibitor or ARB lie in the third line of management, and followed by direct vasodilators. So this is the order of prescription of antihypertensive medications in dialysis. Regarding neurology and psychiatry, I'm not going to discuss with you all neurological dysfunction in hemodialysis, but you can see it may be peripheral, myopathy, neuropathy, cranial neuropathy, and central or cortical neurological complications, central or subcortical neurological complications. All these can be encountered in dialysis patients. This is a very hot issue in nephrology. And instead of waiting until we have cognitive dysfunction, it's better to be preceding this issue by preventive strategy. How to prevent is to monitor cerebral blood flow, because cerebral blood flow can be evaluated by transcranial Doppler or MRI, and by this way we can predict cerebral ischemia before its impact on cognitive functions. Depression is of paramount importance, because in dialysis, depression is associated with increased mortality, increased malnutrition, and other problems in dialysis patients. It is quite prevalent, and it needs collaboration with psychiatrists and to follow multidisciplinary team approach. And the best management is not restricted to pharmacological treatment, but it should include cocktail of physical, psychosocial, cognitive behavioral treatment and treatment drugs. Blood volumes and dry body weight. it is this is one of the important clinical spectrum. We should know how to predict, how to estimate dry body weight in our patients, and to reach the better targets. So dry weight targeting should be one of the important aspects. This is an art to be known for all nephrologists take caring of dialysis patients. How to evaluate dry body weight? It is by clinical parameters, and this is the body weight. Below it, the patient may suffer from hypotension. And we can be supported by technical aspects like the ultrasound. And in this course, we advocate ultrasound for blood volume IVC, inferior vena cava diameter. And here, in the last course that was held in April this year, we have 1 day for ultrasound for central line for the echocardiogram. And in this course, we'll add the lung ultrasound to help us as bedside tool to evaluate the blood volume of our patients. Other body systems, the KDIGO guidelines regarding CKD MBD was released last year, including many issues regarding parathyroid, vitamin D, and phosphorus. And in this course, we'll discuss all these points in details in presentations. And you can review this videotape about the spectrum of CKD mineral-bone disorders. Anemia is very important. This is why today in the afternoon, we have a lecture dedicated for CKD-associated anemia, because some of symptoms that was expected to be because of uremia is because of anemia. So this is why we should know how to diagnose and what is the target for anemia management. If you look here, in the early 2000, in the mid 2000s, the trend was toward increasing hemoglobin. Nowadays, the trend is to keep hemoglobin between 10.5 to 11.5. So the fraction and the percentage of patients with hemoglobin above 12 here in the mid 2000s is reduced here in the current era of United States renal data system. We should know that medicine is founded to improve symptoms. So we should know the commonest symptoms, and insomnia, muscle cramps, and fatigue are of very important for patients on hemodialysis, and this is why we should know them, how to diagnose and how to treat them in hemodialysis patients, to keep them active, because activity and physical function is of paramount importance. And even this is the Japanese dialysis outcome and the practice pattern study shows that vitality measured as self-reported energy level is associated with outcome. Here, if you look, self-reported energy level, if it is no or little, mortality increased, others increased. This is the and hospitalization, for mortality and hospitalization. So it's better to keep our patients full of vitality and energy. Regarding vascular access, we consider it an access for life. And here, this is one of the issues. On initiation of dialysis in the United States, they depend upon catheter in the majority of patients. By the time fistula is created, and I think we should change this, because, for example, in Japan, they depend on fistula from the early beginning, because even there is education and the healthcare system, I think, in this point is superior. And the dependence on catheter to start dialysis is the reason behind increased mortality in dialysis patients. The prevalent dialysis patients, the tendency for creating a fistula is improved, but still needs an action. And this is the increased mortality within the short time after starting dialysis. Regarding catheters, we advocate against the use of central venous catheters for chronic renal failure and chronic hemodialysis. Why? Because catheters are associated with infection, hospitalization, inflammation, and mortality. But sometimes this is the only available, or the patient state doesn't withstand fistula. So we hate catheters, but sometimes this is the only resort that we have. This is why we should look at our patients, addressing the patient's characteristics, age, comorbidities, life expectancy, anatomy of the vessels, patient preferences, CKD progression rate, especially in elderly, surgical expertise, center policy. All these factors should be mixed and blended together to in a shared decision-making process to find the way which is the best for this patients, and this is precision or individualization approach. You may find at the end the best is catheter or fistula or graft. And the message is, if a fistula can be done for any patient, even if he is or she is elderly, we proceed for fistula. So there is no age limit for this procedure with adequate vessels. And adequate vessel is of paramount importance, because one of important barriers in fistula creation is lack of maturity, especially in elderly patients. And this table summarizes the different access type, advantages, and disadvantages. Again, catheter is quick and easy procedure done by all nephrologists, but I don't like them, and they should be kept as a last resort. And this is the review about the clinical and the regulatory considerations when we think of central venous catheters. Yes, all these are benefits, easy, feasible, and can bridging dialysis, it's fine. But we should look at risks. There are insertion-related risks like hemothorax, pneumothorax, air embolism, arrhythmias, tamponade, atrial and venous perforation, dissection, occlusion, and use-related risks like luminal thrombosis, infection, poor function, limited function, longevity, inflammation, increase the rate of hospitalization, increase the risk of death, increase the cost, central venous stenosis, and it's important because central venous stenosis is common after central venous catheter, and this may prevent the future creation of fistula. And as I mentioned, fistula maturation is also an important issue that needs to be refined from prediction and follow up to the treatment strategy. And I think the most practical point is to have your own flow sheet for follow up and periodic examination of vascular access. When to start dialysis? These are different guidelines speaking about the issue of starting dialysis. KDIGO guidelines, KIDUKI, Japanese guidelines. All these guidelines at the end of the day documented and agreed on individualized approach to the best timing for dialysis initiation. So they agreed that we don't dialyze serum creatinine, we dialyze a patient. So we should look at kidney function, rate of progression, the presence of symptoms, volume status. All these points and the age of the patients should be put together to find the best time of dialysis. And sometimes in elderly, frail patients, supportive treatment without dialysis may be the solution after a discussion with the patients. This is the trend of starting the estimated GFR for patients in the United States through the years. And this is the incident in the stage kidney disease, and this the color of a starting GFR. What do you see here? At certain time points, the estimated GFR in the 2010 here was above 15, but nowadays the fraction of patients for whom dialysis started at the level of 15 milli per minute is reduced here in the current era. So the meta-analysis, this is a very recent meta-analysis published this month about the timing of dialysis initiation, where they reviewed all studies. The majority of them are observational studies, discussing it is early or late. And you can look here, this is the cutoff point for early or late, above 7.5, less than 0.7 in this study. Another studies above or less than 5. So, and this is another study above 6.5 early and below 3.3 is late. I don't like early or late, and I prefer the term on-time dialysis. On-time dialysis, we don't like the patients to have dialysis based on numerical values. If you have your patients with estimated GFR less than 15 milli per minute, this means stage 5 chronic kidney disease. It is better to have focused follow-up for everything: blood pressure, symptomatology, rate of progression, and the presence of malnutrition. All these points and the age of the patients put in follow-up to determine the best timing for dialysis of your patient. So instead of saying early or late, I prefer on-time dialysis, and it needs training and expertise of nephrologists to evaluate the best time to start dialysis for the patient. This is regarding chronic dialysis. What about dialysis for acute kidney injury? This is the most recent randomized controlled study regarding the timing of renal replacement therapy in patients with acute kidney injury due to sepsis. Here, there is no benefit for starting earlier and sticking to the clinical indications like overload, hyperkalemia, and acidosis in acute kidney injury patients. Still, timing of kidney replacement therapy in acute and in chronic need a lot of research. Regarding the last sector in the presentation is some health issues. Here I advocate to know the satisfaction of patients, because customer satisfaction is one of the quality indicator, and this survey addressed this issue. So if you give your patient a care and education, the satisfaction of the patient will be higher. Regarding residual renal function, it's better to keep residual kidney function whenever possible, and you should put many lines under whenever possible. Here, this study shows that yes, if you keep residual clearance of urea, if in this range, survival is fine. But if it drops to 1 or 0, survival is reduced and mortality is increased, here 20% and here 40%. So it's better to keep residual kidney function. And how to preserve the kidney function is start dialysis gradual according to the patient needs. And this is known as incremental or progressive hemodialysis. But yes, this study shows that it is feasible and preserve the residual kidney function. But the most important is the prerequisites for prescription of incremental hemodialysis. We should periodic check kidney functions, plus symptomatology, plus laboratory parameters, plus clinical evaluation of malnutrition. So we should look at all these points when we adopt incremental hemodialysis. And the key message, yes, we like residual kidney function, but we shouldn't allow patients to be underdialyzed and to suffer from underdialysis. Regarding the acid-base disturbance, we don't like acidosis and we don't like alkalosis. Ni, kid, ni, means. This means neither in excess. Why? Because acidosis is associated with poor outcome, cardiovascular, loss of residual kidney function, etc. Alkalosis is associated with malnutrition. It may reflect malnutrition, low protein intake, and is associated with vascular calcification. So we need serum bicarbonate to be normal and not to be high at the end of dialysis session. Regarding the aspects, the basic principles of dialysis, hemodiafiltration, hemodialysis, convections and diffusions, all these issues will be clarified by will be one of the most interesting presentation of Professor Sheashaa with this course to clarify the techniques and the principles and the basics of hemodialysis, including, and this is one of innovations in the filter, expanded hemodialysis to get rid of middle molecules and high molecules. Regarding drugs, we advocate against proton pump inhibitors in nephrology patients in general. And here in dialysis, proton pump inhibitors use was associated with increasing hazards of hypomagnesemia and mortality, either total mortality or cardiovascular related mortality. So we should advocate against the use of PPI to be restricted to critical indications. And this is another study shows in comparison to H2 receptor blockers, proton pump inhibitors are associated with increasing risk of fracture in comparison to the H2 receptor blockers. Infection control is very vital for hemodialysis patients, and our target in infection rate should be 0%. And because it is preventable, we should do our best to get rid of any source of infection within hemodialysis unit. Water treatment is usually neglected, and this is why we have in this course a lecture dedicated for water treatment, and we will have workshop inside the water treatment unit, and Professor Samir Saleh will join us in the clinical round in the water treatment, and he will deliver a presentation about the water treatment. I think it's very crucial because some, and I'm not saying majority of nephrologists are not aware by the process of water treatment, and we should know. Another innovations in wearable artificial kidney, instead of going to a center for dialysis, the patient can carry his own dialysis machines, small machines, and even the most fantastic is implantable kidneys. This is still on research. This apparatus is connected to vessels, artery, and vein, and the bladder to get rid of urine. So it simulates the kidney transplant procedure. Even bioengineering kidney, tissue engineering, 3D printing organs, all these are very nice issues to be thought. Back to the practical points. We should educate patients against the issue of non-adherence. So if you have a rate of missed hemodialysis, this is one of the indicators of low quality of the service. So we should educate the patients to have sufficient dialysis, not to escape from dialysis, because, and you can find here the percentage of missing treatment per countries. It is variable from country to country. Here in Japan, it's fantastic because it's very low or absent. And the missed hemodialysis treatment is a modifiable burden in the world. Why there is missed hemodialysis? And I think there are barriers on the level of patients, provider, and health system level. This is why we need interventions that may improve adherence to in-center hemodialysis treatment through the patient level, provider level, and health system level. In patients, educate the patients pre-interstitial disease education, improve health literacy, supporting the patients socially through peer mentoring program, group support, targeted interventions to a risk group, health conditions, screen and treat depression, screen and treat alcohol abuse, screen and treat substance abuse, pain management, quality of life assessment. All these points should be respected on the patient level, and if we take care of all these points, I think this will be very important to reduce the issue of missing dialysis or non-adherence treatment. On provider levels, staff-related and social support and communications, healthcare system, you can look at these points to be addressed on the health system level. At the end, I tried through this presentation to highlight some ideas about the dimension, and as you see, the dimension is very, very huge to cover all issues in hemodialysis, and each aspect through this dimension each aspect needs special and dedicated presentations. At the end of the day, there are still a lot of unknowns, and we should exhaust ourselves to do education, training, research to fill the gaps, and to put in mind that it is not only the issue of education. We need the education to be translated into action, because the great aim of education is not knowledge in itself, but action. Knowledge is of no value unless you put it into practice. At this point, thank you very much, and I'll hope that you enjoyed the presentation, and I'm going to have your questions. Thank you very much. Goodbye.